Welcome back to Confused Neuron. Grab your virtual markers, because today we are mapping out an incredibly fascinating connection between your liver, your brain, and your gastrointestinal tract. We're breaking down cirrhosis, how drugs actually move through your body, and the intricate pharmacology of, well, puke. We are going to draw this out step by step on the whiteboard, writing what we say and saying what we write, so you can lock these concepts into your memory for good. Let's get into the explainer.
Okay, let's dive into this. Before we even touch the complex receptors, I want to start with a crucial question to really get us thinking. What is the absolute most dangerous thing about vomiting? I mean, is it the loss of calories, the acid burning your enamel? Actually, the absolute most dangerous thing here is electrolyte imbalance and volume depletion. You see, if you lose too much fluid and too many electrolytes, you can suffer from severe cardiac arrhythmias or even brain seizures. A severe electrolyte imbalance can literally turn a patient into a vegetable, and that is exactly why understanding the pharmacology of the drugs we use to stop vomiting is absolutely vital.
Act 1. Pharmacokinetics and the liver.
So breaking this down, pharmacokinetics is, simply put, what your body does to a drug, and it always follows this classic four-step acronym, ADME. A is for absorption, which is how the drug crosses a membrane to actually get into your blood. D is for distribution, the process of moving from the bloodstream into your tissues. M stands for metabolism, where your body, and this is usually the liver's job, transforms the drug from an active state to basically an inactive piece of trash. And finally, E is for elimination, where your kidneys usually just pee it out or you excrete it through bile or stool.
Now, we've got to look at the two main types of drugs. Think of a blood vessel. Blood plasma is mostly water, right? So if a drug is water-soluble, it floats freely in the bloodstream, no problem at all. But because human cell membranes are made of lipids, meaning fats, that water-soluble drug gets completely blocked at the cell wall. Access denied. It's going to need a specific receptor on the outside of the cell to get its job done. On the flip side, if a drug is lipid-soluble, it can slice right through that fatty cell membrane like a hot knife through butter. But it has a huge problem navigating the watery bloodstream. Oil and water just don't mix, so a lipid-soluble drug desperately needs a protein carrier, like albumin, to literally carry it on its shoulders through the blood.
And this brilliantly illustrates exactly what happens when the liver gets sick. If we draw out a damaged, scarred liver, we're talking about hepatic cirrhosis. Clinically speaking, you're going to see symptoms like jaundice, extreme fatigue, and easy bruising, which we often classify by severity using the Child-Pugh score. But on a strict pharmacological level, when a patient has cirrhosis, two massive pharmacokinetic nightmares occur. First, the liver simply stops synthesizing those crucial plasma proteins like albumin. And without albumin, those lipid-soluble drugs we just talked about, they have no carriers, completely altering how they distribute in the body. Second, cirrhosis drastically lowers the liver's first-pass effect. Normally, the liver metabolizes and filters a huge chunk of an oral drug before it ever hits systemic circulation. But with cirrhosis, that filtration system fails, meaning the oral bioavailability of these drugs shoots through the roof. The drug levels can quickly skyrocket to highly toxic levels.
Cirrhosis also causes this massive, uncomfortable buildup of fluid in the peritoneal cavity, which we know as ascites. So, what is our treatment algorithm here? Enter spironolactone. It's a potassium-sparing aldosterone antagonist. You see, high levels of aldosterone normally cause your body to retain sodium in water, which leads to severe edema. Spironolactone blocks those aldosterone receptors, which effectively tells the kidneys to hold on to potassium, but excrete all that excess sodium in water. It is absolutely the diuretic of choice for patients dealing with hepatic cirrhosis and ascites. You just have to remember to monitor these patients super closely. A major side effect is hyperkalemia, meaning dangerously high potassium levels, so it's strictly contraindicated in patients who are already suffering from severe renal failure.
Act 2. The Physiology of Puke. Charles Dickens once wrote, "It was the best of times, it was the worst of times, it was the winter of despair." And honestly, nothing says winter of despair quite like trying to study neuropharmacology and brain anatomy for your final exams. But stick with me here, because understanding this reflex is going to make the pharmacology side of things incredibly easy. Let's map out the actual reflex arc. Vomiting is a highly coordinated automatic reflex designed to protect you from toxins, acidosis, or hypoxia. Step 1. An irritating stimulus hits your throat or stomach. Step 2. The vagus nerve, that's cranial nerve number 10, acts as the afferent sensory arm, sending a frantic SOS signal straight up to the brain. Step 3. The signal hits the command center. This is the chemoreceptor trigger zone, or CTZ, located right in the medulla oblongata of the brainstem. Step 4. The CTZ fires efferent motor signals back down. And step 5. You vomit.
Now, what's really interesting here is a massive medical myth we need to bust wide open. During vomiting, contrary to popular belief, your stomach does absolutely zero work. It does not contract. Instead, your stomach is completely relaxed and chill. What actually happens is your diaphragm moves down, your lower esophageal sphincter completely relaxes, and your intra-abdominal muscles forcefully contract. Your abs essentially squeeze that passive stomach like a tube of toothpaste, forcing all the contents up and out.
To really cement the vagus nerve's role in this whole process, just think of the urban legend of the ancient Roman vomitorium. The story goes that rich aristocrats would gorge themselves on food, and then they'd take the back of a wooden spoon and literally irritate the back of their throats near the uvula. Why does that trick actually work? Because touching that area directly irritates the vagus nerve, which shoots a signal straight to the medulla, triggering the CTZ, and bam, reflex vomiting.
Act 3. The Antiemetic Arsenal.
So let's see how this all builds together into our antiemetic arsenal. We are mapping out 3 major drugs, their specific receptor targets, and exactly where they work anatomically. First, we have ondansetron targeting the 5-HT3 receptor on the vagus nerve. Then we have metoclopramide targeting the D2 dopamine receptor right up in the medulla's CTZ. And finally, we have scopolamine targeting the M1 muscarinic receptor located in the inner ear. Let's break down the special side effects and mechanisms for each of these bad boys.
First step on the board is ondansetron. Pro tip, if a drug ends in setron, you can safely bet it targets serotonin. Specifically, it is a potent antagonist for the serotonin 3 or 5-HT3 receptor. By blocking this receptor, it calms the vagus nerve, completely shutting down that SOS irritation signal coming up from your stomach and throat. How do you remember which serotonin receptor it is? Use this classic mnemonic, I always vomit on 3, serotonin 3. It's an incredibly widely used drug, especially for patients undergoing harsh chemotherapy.
Now, the crucial point here is understanding what happens when we start messing with other receptors, like dopamine. Metoclopramide blocks D2 dopamine receptors right in the chemoreceptor trigger zone, so you don't get into the zone of vomiting. But we have to issue a major, very serious side effect warning here. Dopamine is also heavily used in the nigrostriatal pathway of your brain for controlling movement. If you accidentally block dopamine there, you get extrapyramidal symptoms, or EPS. The patient might become extremely rigid, develop severe tremors, or show terrifying Parkinson-like features. Furthermore, blocking dopamine leaves prolactin totally uninhibited, which can cause hyperprolactinemia, potentially leading to galactorrhea.
Finally, we have scopolamine. This is an M1 muscarinic blocker that targets the inner ear, making it absolutely fantastic for treating motion sickness. But if a patient takes too much, you end up blocking the parasympathetic nervous system entirely. This leads to a very specific, highly dangerous overdose state. So I'm going to leave you with this final provocative riddle to test your clinical knowledge. Hot as a hare, blind as a bat, dry as a bone, mad as a hatter, full as a flask. What classic toxidrome is this describing? Drop your answers in the comments below. And hey, if you want to review the spelling of any of these complex medical terms we covered today, don't forget to turn on those English subtitles. Keep your neurons curious, and I'll see you in the next explainer.